Our next speaker will be Dr. Jacquelyne Gaddy, who's an assistant professor at Yale and trained in the States at Loyola University for medical school, then her clinical training at Buffalo, and then oncology fellowship at UNC, followed by a master's there in clinical research. Then moved back to New York, where she did a clinical sciences degree, Master of Clinical Sciences at Roswell Park, and then moved one state over to Connecticut, where she's an assistant professor. Now, I haven't met Dr. Gaddy before, but her title is Closing the Gap, Advancing Health Equity in Cancer Clinical Trials. So I hope she's going to tell us about all these fancy medicines and how we're giving all access to them in efforts to help everyone. Thank you for coming, and looking forward to your presentation.
Good morning, everyone. My name is Jacquelyne Gaddy, and I appreciate the introduction. I also appreciate just being given the opportunity to speak to all of you and to be invited this morning. I also want to thank the patient advocates and all of those that are in the room this morning. Again, I actually will answer that quick question because I think I want to think about the audience. And so I may not talk about drugs in particular, but I will hopefully leave you with some action items on how, when you leave this room, particular steps that you can take to actually make impact and ultimately be able to hopefully contribute to closing the gap. Before I move further, whenever I put something on a slide, it's with intention. I usually move in life with intention. So when we look at the bottom of this slide, moving from left to right, as you acknowledged, I am from Buffalo, New York. You know, I'm a huge Buffalo Bills fan, and I kind of hold still with that currently, since we just didn't make it to the Super Bowl. But at the bottom left, that's the Peace Bridge, and that's what connects Buffalo or the States to Canada. And I think in this current climate, it's really, for me, important to acknowledge the need for continued peace. When we move over to the right, we have puzzle pieces. And I think oftentimes my mentor always says to me, almost everything in life is about a puzzle. You know, some are harder to put together, but just getting the pieces together is usually what ultimately allows us to move forward. So specifically in clinical trials, I kind of look at this as a puzzle and looking for the key pieces to be able to advance and move the needle forward. Moving further to the right, I think much of our life, and when I look at the audience today, you know, there's so much rich diversity. And when I think about diversity, it's not just the color of our skin, it's the walks of life that we've had and everything that ultimately got us to be here today. When we put all of our hands and our minds together, that's ultimately what can help us advance the needle forward. And then lastly, as we all continue to do this work, I would imagine all of those that decided to come to this conference on a Friday. There's so many things that you can be doing on a Friday. For me, I'm usually in clinic. But for you that may not be in clinic, you could have selected to do anything. But because you're here, to me, I would consider that you find what I'm going to discuss important. And right now we're in a climate where silencing us is what's the goal. And I hope that we can continue to think about health equity and speaking loudly, boldly, and proudly. I've kind of give you an introduction already by just moving from left to right on the previous slide, but I will first kind of set some ground rules, go over my goals and what I want to talk about, and then I'll move forward with the challenge. And I want to thank everyone that went before me because you kind of made this a little bit easier. You set me up for success, so I appreciate that. And then the last thing, I think hope is so important. So I always say to everyone, we have to find hope in uncertain times. So I'm hoping to leave you with hopeful solutions when you leave here today. Before we move forward, I like to first give credit to my mentor, my primary mentor, Dr. Pamela Coombs, who leads GI at Yale and is a life and personal and all things mentor for me. But this slide is adopted from a presentation that we gave together some time ago. And it's so important to set ground rules because now more than ever, I never thought when I was actually invited to give this talk, I didn't think I was gonna have to set ground rules here. But now saying equity, saying diversity, saying disparity, it's like a bad word. So I hope that as I speak, we can kind of think about, I'm not here to curse, I'm not here to be unprofessional, but I am here to say this work is important. And I'm hopeful that that will land with all of you as we move forward in this presentation and honestly throughout the day. Disclosures, I'll move quickly through that because I have a little bit more important things to discuss. But disclaimers. Disclaimers are something that my mentor and I, we kind of adopted this idea from someone else, but it's really important for us to think about who we are. So whenever I give a talk, I quickly, like within seconds, will go over my disclosures. I won't even say what they are. I'll just show up the slide like we're supposed to do. But disclaimers are instead very important to me. I'm a daughter. I'm a granddaughter. And I'll mention my grandmother at the end of this because that's really important. I'm a friend. People sometimes get confused, but I'm very much a Black woman, and I'm very proud to say that. I was raised in a single parent household by my mother. And certainly, which I probably can imagine almost every individual in this room, I have experienced racial discrimination in some way. Despite all of that, I am very privileged. I'm a Black GI medical oncologist at Yale. And I say that proudly. It didn't come easily, but that's my privilege. I'm also cisgender and heterosexual. So in some spaces, that's also considered a privilege. And I mention these disclaimers because it's important for us is to say, what privilege do we walk into a room with? We all have to acknowledge our privileges, and I think that will allow us to kind of move the needle forward as well. So I'll first, as I mentioned, start with the challenge. Again, I'm a GI medical oncologist, so I treat I always say from like mouth to anus. Like that's kind of what I do. It's not fancy and glamorous, but that's what I treat. And when I gave my job talk, I chose this slide. And honestly, unfortunately, nothing has changed since that job talk. And when you look at this, I don't need you to go home and have every piece of data remembered or memorized rather, but there's key things that you can see. It's a huge thing that the difference is when we see, first of all, Black versus non-Hispanic white incidents, but most importantly, mortality. Because it's one thing to be diagnosed with the disease, but what my patients care most about is how they're going to survive it. As a GI oncologist, I always say to my patients, I'm the doctor that no one wants to see, and I'm the doctor that I proudly would be fired. I like to be fired when 5 years have passed and my patients don't need to see me anymore. So keep that previous slide in the back of your mind as I advance forward. Again, whoever showed this slide like twice, I'm so thankful because I can quickly glide through that. But this is important. When we look at this slide, now, currently, when we think about colorectal cancer, when we think about Chadwick Boseman, and honestly, not just Chadwick, I can name 15 of my patients if there wasn't HIPAA. But it's important for us to really look at where Blacks are as far as actually being diagnosed with colorectal cancer compared to white patients, and then compared to Hispanic patients. But again, cancer, I have two C words, like equity is a curse word now. Cancer has been a curse word for many years. And chemo is the second bad word as well. So when my patients come to see me, it's not just, well, I have cancer. They also want to know how they're going to survive it. So when we think about these numbers, this is what they're looking for. So I kind of try to stick to the goal. So I was asked to talk about clinical trials, and I'm not going to leave you. You're not going to leave here saying, okay, when I go home, I'm going to use this drug for this. But I want you to go home and say, what can I do differently? For the researchers in the room, for the students in the room, for the fellows in the room that I think a fellow spoke earlier, when you're designing clinical trials, I'm very much not a clinical trialist. I always say that. I'm a health services researcher trying to advance health equity and inclusive excellence in all spaces that I can touch. This is a slide I also showed in my job talk. I knew when I was going to be invited here that nothing had really changed since my job talk. But I have the top part highlighted, and it's really important going from left to right again. When we think about clinical trials, again, I'm going to define something that's really, really important. It's very easy to understand this term, external validity. That's something that when I, was in school many years ago, that always stuck with me. External validity is when I do a study, can that study then be pushed out easily to all involved? And honestly, I always challenge people, where's your table one? Show me your table one so I can see who you included. So then I can know, is this actually externally valid? Meaning, did you invite Black patients? I just showed the slide earlier that said colorectal cancer, Black patients, highest incidence. So I would think as a researcher, if you're going to design a trial, in fact, you would have the patients that are represented the most. This slide here shows, it may not be specifically for colorectal cancer. It's honestly, if I was a breast oncologist, if I was a GU oncologist, it's across the board. So my point here, again, leaving you with goals is ask your patients. We know with clinical trials, the biggest issue, it's not because Black patients don't trust the healthcare system. Black patients don't go to the doctor. Those are all the things that we try to promote in the media. But the facts, I stick with data. Patients aren't being asked. When you ask the patient, do you want to get the best drug that I can give you? And this is the reasons why, and this is how you will get it. I ask my patient all the time. Yesterday, I had a patient, she unfortunately progressed on, there's lines in cancer care. First line, we kind of talked about that. Second line, and now she's on third line. I have a trial for her. I walk in the room, she's excited to see me because I have that rapport with her. But most importantly, I know I have a study. Easily, now she'll be on the study. I've built rapport, I've built trust, and now she can easily trust me. It's not on our patients to develop trust. It is on us as a system to be trustworthy. I always say that when papers are written and say they don't trust us, I get a little cringy because that's not their responsibility. Again, I'm gonna try to also, for the sake of time, as you can see, I'm much of a woman to use my hands, and I'm much of a woman to kind of just let the slides talk for themselves, but also make sure I'm speaking to my audience. This is no different than the previous slide, to be honest. Meaning, Black patients have all of these cancers. Black patients get melanoma. Black patients get lung cancer, whether that's non-small cell or small cell. They get kidney cancer, urothelial cancer. But when you go all the way from left to right, you'll see I really highlighted that column, Black patients, Asian patients, and we don't even know what other is for this, but that's how they identified it in their study. You can see how underrepresented they are. And most importantly, how are we gonna have external validity? So again, I said I wanted to leave y'all with hope because it's a sad time in many people's lives. But despite uncertainties, despite sadness, fear, and a lot of the things that I think many people are experiencing in different ways, I still think that there can be hope. I saw Dr. Hughes Halbert walked in and I knew she was coming. So I am a Dr. Robert Wynn scholar. And this is my second year of finishing this. And I remember, I guess it was almost a year ago, we sat down and it was the first person to really talk to me. So we used to use this term determinants, and that's how it was first introduced. But now many of us in this field, we realize like, it's not determined, it's a driver. Meaning it's not something that's like established. It isn't something that can be modified if we kind of think about structural racism, if we think about disparities and all of the things that we should be thinking as we try to advance health equity. Again, GI oncologist, but when you do this work, it doesn't matter if it's GI, breast, et cetera. So this was in the breast cancer space, but I can easily, again, external validity, use this in GI oncology. This figure is like everything to me. Why? Because within this figure, from that manuscript I just showed, I'm all about left to right. So when we go in the left corner, up top, structural racism, people are like scared to say structural racism. That's why if you literally go to PubMed and put in structural racism, the papers are limited. But I like to stick to facts and data. So structural racism to me and to others clearly in the data, it really determines everything. So up at the top, we see that, in fact, if you are enduring structural racism, you have stress. Like I'm stressed. Literally, I'm sure there is inflammation in my body as a result of this. I'm not even joking, but it's true. I'm glad we can laugh again in uncertain times. But then on top of that, what are the needs of a particular community? What are they exposed to? What type of like hazards and allergens, and again, inflammation. And then at the bottom, moving closer towards getting to what the problem is, which is racial and ethnic disparities, the mediators. Again, I talked about inflammation. So stress, inflammation, epigenetic modulation or modification. All of that to me and to others is what leads to healthcare disparities. So my point in this is, again, I want you to leave home and be like, okay, what is the one thing I can do differently? You can think about the communities that we live in, our patients live in, that are literally structurally racist. Me, again, I said it when I first started. I'm a Black woman. I'm the only Black oncologist at Yale. Yale is great, and that's my institution, and I am proud to be there, and I mean that wholeheartedly. But even Yale, we struggle with structural racism. We struggle with implicit bias. We all have implicit bias. So when you're writing the manuscript, when you're talking to your patient, I always try to pause and say, okay, what biases am I possibly putting into this encounter? Because if you check them and you identify them, that to me can impact at least a few of these things, which I consider all to be targetable solutions. So what do I do, or what have I done? Again, Dr. Coons, who is like one of the top 5 people in my life because of the fact that she really has catapulted my career. So before I arrived at Yale, she, I should say, received a pilot grant. And because she's the mentor that great mentors are, she said, we're going to do this together. So I became the co-PI before I even arrived. And within this study, we really wanted to see within the community of the greater New Haven area, which is where I practice, what are the current understandings of our community for clinical trials? Not, okay, the New Haven community doesn't trust us, so what are we going to do? No, let's see if they trust us. And if they don't, let's determine how we can instead become trustworthy. So in fact, our patients can enroll in clinical trials. I don't sign up for anything that I don't understand. When somebody's like, can you sign at the bottom line? What am I signing? And that's for the same thing for clinical trials. If our patients are actually explained, this is why I'm offering this, this is how it works, this is what I think you'll benefit from, I'm pretty sure that they will sign. But if we don't take that time to say, this is why, this is how you'll benefit, this is your options, to me, that's informed consent. Informed consent is I've given all the options, I've given the alternatives, and I've also explained you could stop at any time. So again, what can you leave home with? When you give informed consent, when my patients sign for chemo, I always start with, this may make you die. I literally say that. Why? Because if something catastrophic happens, I need them to know that we've discussed that. Because again, that's informed consent. I'm going to quickly move through this for the sake of time, but most importantly, we partner with what I would consider stakeholders. In the Black community, my faith is probably what's getting me through much of these uncertain times. And that's really prominent within the Black community. So we knew at Yale that we needed to have liaisons, someone that can bridge the physicians with the community. And at Yale, we have cultural ambassadors, which are basically stakeholders in the community that we partner with to be able to go into the churches and really just have focus groups and learn from our community members. And ultimately what this led to is new infrastructure within Yale to actually demonstrate to our patients that we're listening to them. Everybody wants to be heard. And I think that's what we were able to do from this particular pilot. I promise you I'm getting close to the end because I have my time up here as well. But I always show this slide. So again, I said I'm the only Black oncologist at Yale. That's not because Yale is racist. That's because of this. So 13.4% of the population identifies as Black. It's a funnel system.
I can give my ears.
It's a funnel system. So when we go literally step by step, again, start at 13.4%, they say 3%, it's roughly 2 to 3%, but when we think about intersectionality, so I'm Black, but I'm also a Black woman. So the intersection of that is ultimately what leads me to be about 1 to 2% of practicing oncologists. Some of that is structural racism. Some of that is implicit biases. Some of that is lack of representation. That's why I always accept these invites, because I knew when I was a medical student, there was one Black oncologist at Loyola. And every single time I saw her, my whole day was made. Why? Because I saw myself in her. She showed me, okay, I can do this. So I'm here always to say, I'm on the podium, not because I didn't have clinic or anything that I was supposed to do today, but because I really need the community to see that we can do this. Somebody in the room earlier said something about their public health students, and that resonated with me. I'm from Buffalo, New York, inner city. I always say, I'm not from the suburbs. I am from the inner city of Buffalo, New York. I'm proud of that. But what changed my life was representation. So they just need to see somebody. When you see somebody doing it, to me, that's what moves the needle forward. So again, when we look at this, Dr. Eric Weiner, who is like an uncle to me, but he's also the Cancer Center director at Yale. He would laugh if I said he was my uncle because he is very much a white man. But despite that, when I met with him, like within 4 months of me arriving at Yale, I am like, again, I have a goal. And my mentor makes sure I stick to that goal. So she's like, you're going to meet with Dr. Weiner when you first get there. I need you to have an agenda. Say less, agenda done. I go meet with Dr. Weiner, and like literally within the first 4 minutes of the conversation, I'm telling Dr. Weiner, okay, so this is what my legacy is going to be. He would literally be cracking up if he was in the room, because he's like a 60 to 70-year-old white man that's like, why is Jackie in my office talking about her legacy? Because he thought that was too soon. But to be very honest, as a Black woman, my legacy are the students that's going to come behind me. The students that saw me speak at something that said, okay, Dr. Gaddy did it. My fellows at Yale and anywhere else that I feel like I can actually impact the community. So again, to me, it's about building your legacy. So what else can we do? And again, I'm big on giving credit. So this slide was actually presented at ASCO GI by my primary mentor, Dr. Pam Coons, who gave the keynote address. But when she gave this talk, we partnered together for her to be able to deliver it. In many ways, because when we think about health equity and me being at Yale and that being my goal to advance the needle, we learn together. So again, I'm here to hopefully say there are some goals. So what can we do as researchers, as students, as patients? The eligibility criteria right there alone is an issue. I'll get a trial and it'll say the ANC, the absolute neutrophil count, has to be 3. Black patients have a historical challenge with maintaining that right there, structurally racist. EGFR, that is a race-based metric, but it has to be within a certain criteria. How are my patients going to get on the trial if you are basically saying from the get-go, right when the race starts, Black patients are already behind? Structural racism. I had a patient who is Vietnamese who got to the States like, I don't know, 3 to 6 months ago. He wanted to be on this trial so bad. I had everything in place, but because he was Vietnamese speaking, it was going to take 8 weeks for them to translate it. And I could not get him on trial. And now he's on standard of care. Again, structurally racist. I don't live and I don't work in a rural community, but some of my patients come from rural communities. They need to also know about trials. They need to know what they're available to get. Also, if my patient I said my mother was a single parent. If my patient is a single parent and has 4 kids and works 3 part-time jobs, plus 1 other job she has no babysitter, how is she gonna come for all the PKs? We need to limit that. Some of that is not necessary to actually advance the science. Think about the patient when the studies are designed. And then lastly, I always, again, try to give my flowers while I can, while the people are still here. So I always give flowers to Dr. Robert Wynn, who is also from Buffalo. He will also always say that to me. But he's centered right in the front. And then right behind him, actually, to your right is Dr. Roy Herbst, who leads hematology and oncology at Yale, one of my champions, I would say. But Dr. Wynn is the reason I'm on this stage as well. He funds a lot of my time at Yale to be able to come here and to be able to do the work that I consider to be important. And then I use this term that's actually coined from Dr. Kimmy Dole. If you don't know her today, I hope that you know her by tomorrow. She is someone that, she's one of the people that when I see her in the room, I am like, oh my God, Dr. Kimmy Dole is here. But she's also someone that I certainly am a product of her coaching. She has a program called Get That Grant that I continue to still participate in. But she developed this term called an informed believer. Because you have believers like, yeah, I think Jackie could do this, but maybe, I don't know. But an informed believer is someone that we recruited Jackie to Yale. Yale can be structurally racist because every institution can be structurally racist. We need to knock down some barriers so that Jackie can walk into the room, sit at the table, and be successful. To me, that's an informed believer. So before I get to the middle picture, I got to look at the left and I have to look all the way to the right. Dr. Willie Underwood was like one of my first mentors after I graduated from Spelman College. I always like to acknowledge me being an HBCU graduate as well. He still mentors me. And then to the right, Dr. Lori Pierce, again, if she walked in the room, it's like Barack Obama walked in the room to me. Why? Because that's the first Black female president of ASCO, American Society of Clinical Oncology. She was the president during the height of COVID, during George Floyd. She didn't let that stop her from talking about equity for the first time in ASCO. So I always give my flowers. I literally just emailed her with some flowers like 3 days ago. But in the middle, if Pam was here, she would cry probably. Why? Because she recruited me to Yale. She didn't know even how she was going to mentor me because she had never mentored anyone from an underrepresented group. So she literally did all the work she could do to get me there, but then more importantly, to keep me there. So I probably will never leave Yale unless Pam is leaving Yale or Eric is leaving Yale. Why? Because they have made sure I sit at every table. And if I'm not at the table, they're going to make sure when they're sitting there that Dr. Jacquelyne Gaddy's name is going to be mentioned. So the reason I show that is for the mentors in the room. You don't have to be last author on everything. You don't have to be first author on everything. Let your mentees do that. If you have a Black recruit, be intentional about them. A minority recruit, be intentional about them. They didn't have the same start line. I started about 15 steps back from my counterparts. My mom always used to say, you got to do it twice as hard. Why? Because when I show into a room, I have to make sure I'm about twice as much in order to be able to stand in front of all of you and to do this successfully. So what do I want you to go home with? Racial and ethnic disparities in cancer care, they're gonna remain a burden. Regardless of what administration says, it is just facts. That's what the data shows. So again, despite uncertain times, we gotta put more pressure now. Our patients still need us. You all will still need us. Somebody in this room will be a patient or currently is a patient. And then again, look at the data. Just implement effective strategies. So again, think about the social drivers of health. Think about inclusive excellence. That's what I call DEI. It'll be called something else tomorrow, but for now I call it inclusive excellence. And then identify barriers as quickly as you can so that your patients can jump over them and be on clinical trials. And then to the right, Pam, Dr. Coons, excuse me, she created this right before I came to Yale. She always modifies this, but it's all together. So inclusive excellence or workforce DEI, innovation, all of that coming together is to me what impacts the science, and Dr. Coons created this to also demonstrate that. And then sorry I went over time, but I hope that impacted all of you. But I can't leave the stage ever without acknowledging my grandmother, the late Roberta Bergen, who raised me, who whenever I wore my white coat, it was like, I don't know, she thought I was like Beyonce or Michelle Obama for this matter. But she came to my white coat ceremony. But by the time I got to my last year of medical school, my grandmother had lost weight. My grandmother wasn't eating. My grandmother was diagnosed with pancreatic cancer. And I learned my bedside manner. I learned to be my authentic self on the stage, in the room, because my grandmother gave me the opportunity to say to her, there's nothing else we can do. So when as a fourth year medical student, I said, okay, oncology it is. My grandmother, blood, sweat, and tears got me to that. And so now I have dedicated my life literally to my grandmother. So I always say to my patients, I give granny level care. My grandmother isn't here, but I treat my patients as if they are my grandmother. I also have to acknowledge Dr. Pam Coons, who I had shown throughout this presentation, my primary mentor, Dr. Robert Wynn, my other mentors who have been in the room as well, Yale, Kimmy, and everyone else. Thank you.